or all PAs take money.
Yeah.
Anything you want to go with, which obviously stands for aortic, pulmonic, mitral, tricuspid. So the sound reaches the chest in that area. It just shows the direction of blood flow from the mitral valve, from the atrial valve, and that's basically what you're hearing. On the right, you see the illustration of the heart showing, the phrenic nerves running by it. They're what supplies the diaphragm, moves it up and down. Sometimes you can get, tumors of the mediastinum or of the lung that can cause obstruction and lead to paralysis of those. So just general anatomy, I'm sure you guys have gotten plenty of this. When looking at the upper right picture up here, you see the right ventricle. And you notice the wall thickness of the right ventricle is obviously a lot less than that of the left ventricle in the right lower picture. But they both have some similar features. They both have, papillary muscles connected to chordae tendineae, which are connected to their valve, their respective valve. Obviously, the right ventricle has the tricuspid valve, and the left ventricle has the bicuspid valve or mitral valve. So I'm not going to get too much into the details about anatomy. I'm sure you guys have had plenty so far, but we'll just move on. So this slide right here is lengthy, but it gives you all the different clinical problems that you can have, as well as some of the imaging that you get for it. Generally, with most cardiac issues, people are going to come in with chest pain. They'll come in with, congestive heart failure, all these different things. Pretty much for all cardiac issues, you're going to start out with PA and lateral films. I don't really know anything that you're going to not start off with PA and lateral films if someone comes in the ER. Someone comes in with chest pain or CHF, usually get your x-rays, start O2 sats. Nowadays, most people just, get a bedside echo right then. And then they can assess ejection fraction right there. Very easy, tells a lot about the function of the heart. So specifically for this slide, there's just a couple different ones I'm going to point out. So the clinical problem over here on the left, renal artery stenosis. I know you guys had hypertension lectures earlier today. So one of the studies that you can do for that specifically is nuclear medicine captopril renogram, which basically you inject a nuclear radioactive into your veins, basically. You image the kidneys over time, and then you give them an ACE inhibitor. And what that does is if your kidneys, if the renin-angiotensin system is very highly activated, then it'll stop that activation, and depending on what radiotracer it is, you'll either see more or less within the collecting system. So that's kind of specific for that one. Also, another one that you guys are going to be coming in contact with all the time, especially if you work ER shifts, is pulmonary embolisms. So, someone's had a prolonged immobilization or just had surgery, or went on a 12-hour plane flight to China. These people are at risk for, developing DVTs at the leg, or of the deep veins, and then having a pulmonary embolism. The imaging study of choice for this would be spiral CT. Some people can't have the contrast for CTs because their kidney creatinine is too high. Sometimes people use a cutoff of 1.5 or 2. In general, if that happens, you can use a DQ scan. Okay. The only other ones I really am going to talk about is just generalized chest pain. There's plenty of things you can do. Like I said earlier, you can do echo. You can do a nuclear sesamoebe, which we'll get into later. And then if you have a really, really high suspicion that these people have coronary artery disease, then you go ahead and do an angiogram. And most of the vessel things you see at the bottom, the carotid bruit, the deep vein thrombosis, all these things can be diagnosed with ultrasound. Okay? So I'll start off with the first case. So 24-year-old male comes to the ER after getting stabbed 1 inch to the left of their sternum, right where that star is right there. The knife is in what structure? So I'll give you, 20, 30 seconds to think about it. Alright, so this is actually a classic anatomy kind of board question that I was actually asked in one of my boards. So it's actually the right ventricle. And I'll show you exactly why, just like the anatomy of it. Because once you're able to understand just the axial anatomy, I think you'll be able to look at a chest ray a little bit easier. So if you look at this cross-sectional anatomy, you see that the right ventricle, it abuts the chest wall. So up on the picture, up here, this is anterior, this is posterior. So you have the right ventricle abutting the chest wall. The left ventricle is kind of in back of it. So when you're looking from the front, you're really looking mostly at the right ventricle. And you can only see a little bit of the left ventricle. It kind of overlays on itself. The same with the right atrium to the left atrium. And then, of course, you have aorta back here. So, also I wrote in here, so when you get right ventricular hypertrophy, say you have like pulmonary hypertension, and that hypertrophies, that's the reason you get that sternal heave right here in the middle of the chest. So,
could you go back to that?
Sure.
Where are we looking? Like, what is this?
This is a cross-sectional picture of a heart. So this is an axial CT scan. So when you're looking at a CT scan, you imagine that someone is kind of transected, like right here, and you're looking up at them. So this is the anterior wall. This is the chest wall, the front, like your chest. This is the left side of your body, the right side, and this is your back. So here is like a vertebral body, aorta, left atrium is posterior, left ventricle is posterior, and the right ventricle and right atrium are both anterior to that.
So if you got stabbed in the left side, you would hit your left atrium.
If you got stabbed, so
it's
it would be hard to
anteriorly.
hit your, if you got stabbed on the right side, you could hit your right atrium, correct?
Oh, I meant left ventricle, sorry.
Oh, you
Left
could
side
hit,
is
so
that one.
if you can imagine this is the whole chest, if you got stabbed very far to the left, like all the way over here, then yes, you could theoretically get stabbed in your left ventricle right here, but you see there's only like a little window right here, but there's this whole window for the right ventricle.
But remember that picture I showed you guys yesterday, that ablation procedure that my mom had, where they were looking at the back side of the heart because they were ablating at the pulmonary arteries, which they were looking through essentially like when they do a posterior, they go down the esophagus and look at the back of the heart so they can see the left atrium. That picture depicts that's how you can look at the left atrium from the back. Because the left atrium is closest to posterior. See that?
So there's various cardiovascular conditions that are seen on X-ray. In general, we're going to go through CHF, mitral stenosis, regurgitation. You'll see some pericardial effusions. PEs, not as easily diagnosed on a chest X-ray. Pulmonary arterial hypertension, depending on how large the artery actually gets, it's sometimes pretty easy to diagnose. And I can show you some of these. And all of these, really, you can diagnose off chest X-ray if it's severe enough. So here's a picture of, a normal chest. Things to look for, just in general. I know I was originally taught in medical school airway, breathing, circulation. Airway, you can look at the trachea, and this is the carina right here. If you can see that little hypolucency going each way to the left and right main stem. Here's the mediastinum. We have the aortic arch right here coming down, over. And then we have the left atrium, left ventricle, but remember the left ventricle, you only see a little bit of it because the right ventricle's superimposed over it, because it's in the front, and the left ventricle's in the back. So when you have left ventricular hypertrophy, the left ventricle gets big and it comes over more lateral. When you get right ventricle hypertrophy, it comes more anterior, okay? Because that's kind of the situations of those two. Right here we have the right atrium, left diaphragm. See the costophrenic angles are clean right here. Nice, very clear. You can distinguish them easily, so there's no pleural effusion. This is a normal pulmonary artery kind of picture. This as well. Sometimes these can get really engorged, and that's kind of a pulmonary arterial hypertension. Okay, so for cardiomegaly.
Abnormal.
Yeah, it's obviously abnormal. So does anyone know what normal is, like size criteria for how big your heart can be on a chest X-ray? Yeah, so half your thoracic. So it's on a PA film, which means like a normal chest X-ray that you go and you get a standing chest X-ray, 50% of basically the width of your thoracic cavity. Unfortunately, a lot of these people can't get PA films. They have to get like AP films in bed because they're ICU patients. They can't expand their lungs very far. And those are, because of those two reasons, if you get an AP film, that's just like them sitting in bed and they're not able to expand their lungs, the criteria is more like 60%. You don't need to know all that, but just so you know, when you're looking at films and you see like, a patient looks like they didn't have cardiomegaly before and then all of a sudden they do, it could just be the way that they shot it based on that. But in this one, it's clearly cardiomegaly. It's probably 75%, 70% of the thoracic cavity. There's a huge left ventricle. The right atrium is severely dilated. So there's no getting away from that. So this is a clinical picture, or probably a diagram of congestive heart failure and pulmonary edema. So the three things we look for in pulmonary edema is, one, is the heart big? Two, is there pleural effusions? And then three, is there, this is perihilar edema, and is there interstitial edema? So those are the three things we mainly look for in, CHF and pulmonary edema. First, what you get, the first sign actually of, it kind of shows it here, of pulmonary edema is what we call cephalization of the pulmonary edema, which means, see how this kind of tracks up a little bit? That's kind of a good depiction of cephalization. So one of the progression of CHF may be one of the only signs that a patient's CAD is progressing or getting worse. It says also here that viral infections can lead to CHF. And that is true. That's mainly true for cardiomyopathies. It's the main cause of cardiomyopathy is viral infections like Coxsackie. I think it's Coxsackie A. I don't really remember. Okay, so we'll take a break from pictures for a second, and we'll talk about two important things. One of them is cardiac output, and the other one's ejection fraction. So cardiac output is basically a measure of the volume of blood that your heart pumps per unit time. That's pretty much all it is. So it's measuring your stroke volume, which means how much volume is your left ventricle pumping every time it pumps, times your heart rate. So if your heart rate is 100 beats a minute and your stroke volume is 200 milliliters, then you're pumping
20 liters.
20 liters a minute, exactly. I'm just making up a random hypothetical. So, and then ejection fraction is also important. This is more of a measure of efficiency of how your heart is pumping. So it's getting your end diastolic, which is your max capacity of your left ventricle after it's completely expanded and sucked all the blood out of your atrium. And then once it's fully contracted and ejected all of its contents, into the aorta, that's end systolic. So it's basically how efficient is your heart, and that's all over end diastolic, which is would be its baseline. So this is an example of a pericardial effusion. So this first image, it's kind of really unremarkable. The heart might be borderline upper limits of normal, but then a week later, it looks kind of enlarged. It looks a little bit different, and these are both PA films, both shot the same way. So in this case, in this instance, the side of the heart represents an effusion in the pericardium. So what EKG findings would you expect with a pericardial effusion? Do you guys know? No? Okay. All right. We'll move on then. It's basically, you can get basically low QRS voltages and something they call electrical alternans. I won't get too much into it if you guys haven't gone through it, because I don't want to get you guys confused. Okay, so we'll talk a little bit about mitral stenosis and mitral regurgitation. So anytime a valve is incompetent, right, you're going to cause dilatation of the segment in back of that. So if you have mitral stenosis, you're going to expect that you're going to have left atrial dilatation. If you have mitral regurgitation, you're going to expect that you have left atrial dilatation, okay? So in both of these, you're going to get pressure back into that atrium for different purposes on both of them. That's going to cause pressure into your pulmonary arteries as well. And that's why you have pulmonary arterial hypertension in here. So you don't normally see a bump for your left atrium like you do in this picture. So you could say that this left atrium is a little enlarged. The pulmonary artery, you can't really say too much about that, honestly. But in mitral stenosis, one thing to note is the heart is not too big. It's, upper limits normal most of the time. It's not, massively enlarged. So, yeah. This is another depiction of left atrial enlargement right here. And significant here, this is a better picture of pulmonary artery hypertension. So it almost looks like a hilar mass. There's a different radiological sign called like hilum overlay sign, and I won't get into that again, but that's kind of a sign that shows that you have pulmonary arterial hypertension instead of a hilar mass. This is something that I wanted to show you guys. So this is called double density sign. So whenever you see a chest x-ray, and it looks like you have, if you see this density right here, this is the left atrium right here, in back of the right atrium, okay? So you get this double density sign right here, and it just means that you have left atrial enlargement. And you can tell when you look on the lateral x-ray that you have this posterior enlargement right here of the heart. This is supposed to be, you know, kind of straight down. You're supposed to have a nice window in between your spine. You're supposed to be able to see, you know, clean lines of trachea, but there's really nothing back here. Or, yeah, there's nothing back here. It's totally obliterated by this enlarged left atrium. So we'll move on to case 2. So what is the most likely etiology of heart disease based on this chest X-ray? And I'll give you guys like 30 seconds to go over it and figure out what you think.
Whoa. A or C? A or C?
Regurgitation?
Yep. Actually, good job. So why did you think regurgitation?
Well, because stenosis wouldn't enlarge it.
Okay, that's good.
And then aortic dissection, I think it would also not.
It would be a
Exactly, you'll have mediastinal widening with the dissection. And aortic stenosis, I mean, you might get an enlarged left ventricle, which is typical of aortic stenosis, but not a massively dilated heart. Another thing that this X-ray shows right here is if you can see the carina clearly right here. This is called splaying of the carina, which means the carina is normally kind of at an acute angle, and if it's pushed into more of like an obtuse angle, like more than 90 degrees, it's called splaying of the carina. And that's kind of, those are the two findings. And the enlarged heart also favors regurgitation over stenosis, like we were saying earlier.
What's the ringy thing?
Which one?
Like, you got down the middle, there's like those, no.
Oh, these?
Yeah.
Oh, okay, so this is a change of median sternotomy wires. So when someone has a coronary artery bypass grafting, they, if you've ever seen any type of cardiac surgery, they, you know, basically have to pry open your chest and then close everything with sternotomy wires. So that's typical for a patient that's gone through a CABG procedure or had their heart opened up for any reason. Okay, so why is the cardiac blood supply so important? It's because coronary arteries are in arteries. They don't have any anastomoses to any other arteries. They fill in diastole. So as you know, the ventricle is relaxing and sucking in that blood, so are the arteries, the coronary arteries. So the cardiac tissue, the myocardium, extracts almost all the oxygen required as it's going through the heart. So if you have any not any stenosis, a significant stenosis up to, you know, 70 degrees or 70% stenosis, you're going to have, you know, start having tissue ischemia, start having symptoms, angina, things like that. So there's a lot of stuff going on in this slide. So I'm just going to go through a little bit of it, and I'm sure you guys know a lot of the anatomy, but some of the main things you need to know is obviously the LCA, which is left coronary artery or left main, starts right here, and it gives off the left anterior descending, and then more laterally, it gives off the left circumflex. The right coronary artery, in 80% of people, goes backwards and supplies the posterior of the heart via the PDA, okay? There's 20% of the people it comes off of the circumflex slash LAD area, but for the most part, most people, the posterior of the heart is supplied by the RCA. You also have these little branches coming off, the circumflexus OM1 branches and the LAD diagonal branches. You probably don't need to know too much about that. As for the conduction system, one good thing to know is that the SA node, is the pacemaker cells of the heart, right? So they have the automaticity that keeps your heart going. Those cells are supplied by the RCA. So if you're having an RCA occlusion, you can have, an increase in arrhythmias, all these types of things. And this is a good schematic because it tells you, the SA node, it goes to the AV node after that, then you go through the bundle of His, and it breaks into the left and right bundle. So you can see that if you had a conduction abnormality at this one right here, why you'd have a complete heart block, because you'd have complete dissociation of, the firing of the left and the right ventricle. While if you just had, at number 2, you'd have a left bundle branch block, and number 3, you'd have a right. So that makes a little bit of sense. Up here on the right shows just a picture of kind of like the pericardium of the heart, which is the outside covering. You have a visceral pericardium and a parietal pericardium, just like the lungs. Very similar to that. The parietal is a lot denser, a lot more hard than the visceral. But you can get buildup in this cavity from effusion, infection, a bunch of different things that can cause cardiac tamponade, which is a little bit more serious. So here's a lateral film that shows a calcified coronary artery. We typically don't see this very much, so I mean, if you were to pick this up just randomly, you'd be pretty good. But we don't typically see this very often. So and this is just coronary angiography, basically using fluoroscopy. They're injecting contrast dye into the arteries, looking for a blockage. In this case, the RCA is blocked. You can see by that little stenosis right there. When they're doing this, they go in there with a catheter and pass a wire across the stenosis, fill it up with what's called angioplasty, which is basically they fill a balloon over the stenosis lumen and try to blow it up, and then place a stent across it most of the times. That's what the cardiologists do. So, yeah.
When you say that the RCA supplies the SA node, what exactly do you mean by that?
So we'll go back a little bit.
That's the nodal cell.
Correct. Yeah. So if you look over here, the right coronary artery is the artery that brings off the supply to the myocardium that the SA nodes are in.
Okay.
So if you had a complete blockage of this RCA proximal to the arteries that bring off the arteries to the SA node, then you could have dysfunction. You wouldn't have automaticity that you normally have. So there's multiple indications for coronary angiography. The main ones that you probably need to know is people that are having unstable angina, which means they're having chest pain at rest, it's sporadic, they'll probably benefit from a revascularization procedure. Also, people that have had stress tests that have shown to be positive for reversible ischemia, those people go in for coronary angiography, usually for stenting. There's a bunch of other different ones, patients that have already been revascularized that are having symptoms again, or people that have gone to surgery and are having symptoms again. But the main ones really are, people that have been tested with multiple tests that show you have reversible ischemia or people that have unstable angina. So some of the important findings that you'll see on coronary angiography, if you have a narrowing of more than 70%, you'll usually have symptoms, and you'll usually have symptoms at rest. So, like unstable. If you have narrowing of 50%, it's pretty significant. In these cases, usually you're stented, and we'll talk about that a little bit more. There's different types of stress tests that are done, and again, we'll get to that in the future. But if you have a positive exercise EKG test, which means they want to test you, right? So they want to see if you can run on a treadmill X amount of times without having chest pain and without having EKG changes, or you have, let's see. Yeah, so those patients will have 3-vessel disease or left main disease the majority of the time. This says 75 to 95% of the time. We were talking earlier about PE studies, same with angiography. So if you have a creatinine over 1.5 at the time, they're not going to take you back because the dye can throw you into acute kidney failure at the time. Also, creatinine of greater than 2, I guess anytime, they're not gonna subject you to that either, unless the benefits outweigh the risk, which kind of is determined by the cardiologist at that time. So one of the ways that they get around this is if someone has CKD and they have a creatinine of 1.3, one thing you do is you bolus them with IV fluids. So you'll give them a couple liters over a couple hours of normal saline, and that's been the main thing that has shown an improvement in outcome of putting people into contrast nephropathy, okay? Contrast-induced nephropathy. Some people also use acetylcysteine, which is Mucomist, for 2 days and then do the contrast study. From what I've read and from what I did last year, we treated everyone with IV hydration for 2 hours before and 2 hours after the procedure. But Mucomist is done by multiple facilities. All right, so we were talking a little bit about coronary angiography, and it basically requires a bunch of different views. So you basically have, if you look at this picture over here on the left, you have kind of a rotating device that's going around the patient. You're taking different pictures around the patient, all these different views, RAO, LAO. All that means is which side is oblique and which side is down. Right anterior is oblique, left anterior is oblique. And then you're injecting contrast directly and seeing real time whether there's stenoses, and then they're performing procedures real time right after this. So myocardial stress imaging. We'll get into some of the echo, the nuclear imaging, and then MRI stuff, okay? So I'm going to talk a little bit about cardiac stress tests real fast in general. So you have to have a mechanism of putting stress on the patient. And then you have to have a mechanism of monitoring the heart's response to that stress. So that's basically what a cardiac stress test is. The stressor could be exercise, it could be dobutamine, which is an anergic molecule. You could have a molecule that dilates, which is like adenosine or dipyranamol. So all of these you use to stress the heart. And then what you want to do is you want to look at the heart before it's stressed, and you're basically taking pictures of it before, and then you're taking pictures of after you use either these agents or exercise to stress. And the way that you monitor is either by EKG, so you're looking for T-wave inversions, ST changes, all these things. If any of those happen, it's a positive stress test, and to send them to coronary angiography after that. Echo. What echo uses is it's using wall motion abnormalities. So you give the patient, for instance, so this is a kind of important concept. So dobutamine, or we'll say adenosine, is a vasodilator. Naturally, your body releases adenosine already pre-made in your body to vasodilate the coronary arteries. When you have a blockage, say of your LAD, the diseased segments are not able to vasodilate, okay? They stay stenosed, and the rest of the heart vasodilates that are not diseased. So what that does is it induces that part of the heart, say that LAD, it'll induce that to show EKG changes, or show echo changes would be like a wall motion abnormality, and then nuclear imaging changes would be like a defect. And I'm going to show you all these in just a second. But I just wanted to run through real fast, what the expected normal is and what images you're looking at. So, indications for a non-invasive cardiac testing. So, this is someone that has stable angina, that can work out. You can't put someone with unstable angina on, a treadmill and make them run, because they'll have pretty bad heart pain. So these people, the other thing is, these people have to be able to get to their target heart rate. So you have to have someone that's generally healthy. You might be able to make like a 40-year-old person do this, but you're not going to make a 65-year-old person do this, or someone that, is in a wheelchair. It's just not going to work, right? It's just not possible. So there's a bunch of different ways, but basically, like I said earlier, you're looking for ST segment elevations or depressions more than a millimeter on a 12 lead EKG. Looking for T-wave inversions, specific patterns.
Is that while they're doing a stress test, or is that what they have to make them do a stress test?
So it is. So if you're going to do an EKG stress test, then the patient should have a baseline EKG, and then you basically have them hooked up to an EKG machine while they're working out. And then if they have chest pain, then it's a positive test. If they have any of those signs, of the EKG that show ischemia, so say they have ST depressions, right? That means ischemic heart. So they'd stop the test right there. They have T-wave inversions, same thing. They'd stop the test right there. It's a positive test. They go get cath.
Okay.
So, yeah, contraindications. Basically, unstable angina, or if you suspect already a myocardial infarction, you just go to coronary angiography. And also, when you do these tests in women, it's very misleading. So they don't even do it for most of the time. It's because there's way too many false positives. So I think it goes into that a little later into the discussion. So other considerations. So if you're asymptomatic, then this is not a good test, because a lot of people are not going to be able to finish the test. It's actually a very a hard test to do. They actually would make all the interns do this. It's pretty tough. They incline you up and progressively make you go faster and faster. There's 5 phases, and it's really hard to do. So you can get to like 4 or something if you're like in really, really good shape, and you have to be like a world-class athlete to get to 5 or something. It's crazy. Yeah. So So it's used in occupations where there's high risk if undetected airline malady. So other different things. You guys can read through that, I'm sure. So this is actually the stages. So this is the Bruce protocol. So they basically start you off in stage 1 is 3 minutes, and they progressively incline you and make you go faster and faster and faster. It's really the incline that gets you, not really the amount that or the fastness that you're running or how long you're running. So, but it's pretty tough. So for a positive test, 1 millimeter ST depression, or there's something called the J point at the end of the S wave. If you have a downsloping of that J point by 1 millimeter, it's the same thing. So around 70% of the patients that meet this criteria have significant disease. So, and there's going to be some false positives. There's 20% false positives. So let's see. I don't exactly know what this slide 100% means, but I left it on here because I didn't want to take slides off because I know that you guys, I don't want to mess up whatever slides you have for tests, and I know when people did that in our lectures, I got angry. So I was like, you took our slides, So I didn't really understand, so I'm not going to go through this. But, I didn't know what it was set up for. I mean, these are the stressors over here. So you got the treadmill, the inotropic, which means the ones that make you pump faster, and then the vasodilators, adenosine. But I don't know what the yes and no's are, so I'm sorry.
So Julie, what they use, the modalities are the stressors and what they use in each of those tests. So on an EKG, they'll use an EKG for a treadmill. I don't know why it says no for the other two, because they're, I guess, you're not actually using your EKG for that. They're using that during your echocardiogram and during the nuclear medicine study.
Oh, okay.
What is Europe?
Sorry, drop the ball on that.
What is Europe? Yes, like in Europe we do that?
I guess. It's a combination. Actually, Professor Lovebaugh did this presentation, and I kind of helped facilitate it last year because of my experience and her recruiting it. So, for some reason, they had her teaching radiology, and then I had more experience, so I kind of came in and helped her. That's how that played out. So, sorry about that. It won't be on your test.
Okay, so here's the thing we were talking about earlier about treadmill tests in women. So if you have middle-aged women had no coronary artery disease and send them for testing, then you get like 40% of them are going to have false positives. So you're going to be capping 40% of your patients. Like, it's just totally unnecessary. You can do other different types of testing, nuclear testing. This says thallium. Thallium's an okay test. It used to be used a lot more often 15 years ago-ish, but since they're using something called technetium-99 sesamoibe, don't worry about it. Everyone calls it a MEB, so for short. So if you ever hear MEB, that just means nuclear stress test, and they want to see if there's reversible ischemia. And I'll show you some pictures of that. So this is talking about using basically echocardiograms. So the best thing about an echo is that it gives you real-time values. You get to look at the heart, right? You get to see the wall motion. You get to see it contracting. You get to see, it resting in diastole. So you can see a bunch of different things. The main things is you can see ejection fraction, which you want to have an ejection fraction of over 40, 45%. You can see whether you have diastolic heart failure or systolic heart failure. So by using that, ejection fraction and seeing how much the heart moves in diastole, you're able to see these things. So those are like some real-time measurements that you can get that is going to be able to tell you if the patient has congestive heart failure. So you use sound waves to look at the heart and evaluate all the valves. You can see the mitral valve, tricuspid valve, aortic valve, pulmonic valve, and you can see whether you're having regurgitation. You can see whether you're having, stenosis. Pretty much, it's a very, very good diagnostic tool, and it's probably going to be used more often than not as a first-line diagnostics, just like a chest X-ray. I mean, the chest X-ray and the echo are ordered at the same time. It just takes longer for the fellow to get there and go do the echo. So it usually is not done for a couple hours. Are we going to show an echocardiogram? I didn't know about this. I was just...
Yeah, you can.
Okay.
Yeah.
Oh, no, I mean, you just said it on here. I thought maybe you had it set up. I didn't know.
Well, I saw, when I flipped through this earlier, I saw a web address. So I thought that's what the next slide was. That's what I thought you were talking about.
Okay. So my next slide was go to break or not to go to break. Because I wanted you guys to
No break, just go.
They're ready to get done.
Unless you're sure.
I know. That's the way I was too. I was always like, no. Let's get down.
Do it on yours already, bye.
Should we wait or no?
We got it.
Okay. This is just a nonsense slide, really. It just this is kind of like the calculations that the computer uses for ejection fraction. Really, all you need to know about the ejection fraction is that the end diastolic minus the end systolic over the end diastolic.
Whoa,
That's, yeah, if you get that, then you're good. Well, that was like one of the earlier slides, sorry. You don't need to know this one. So this is a test that was being heavily used, I would say about 20, 30 years ago. It's multiple gated acquisition scan, and what it can tell you is it can basically tell you a really precise ejection fraction is what it can give you. The reason it's not being used as often now is because the availability of echo. So echocardiograms are available at bedside. You don't have to put this patient into the scanner and do a nuclear test. You can just do everything at bedside. So now, pretty much, this is not happening very often anymore. It does happen, though, for people with cancer, and we'll get into that. So, how this is performed is you basically attach a radioactive substance, which is that Tech-99, the same stuff that that we were talking about earlier with the Sesame B scan. So the Tech-99, you attach it to red blood cells and inject it into your bloodstream. So you have this gamma camera in front of you, which is the thing over this guy's chest right here, okay? And as your heart's pumping, a gated sequence, which is partially what's in the name of MUGA or MUGA or however you want to call it. A gated sequence means that it's taking precise images during the cardiac cycle. So it might be just in diastole or just in systole. And that gives the patient a lot less radiation. So that's why it's gated. That's what that means. Yeah, we'll move on. But basically, this gives you a very precise ejection fraction, and it can also localize areas of previous heart attacks where you have heart muscle loss or damage previously. I don't know how to read these scans because again we don't really use these scans anymore, especially at our facility, but I know they still use them at a lot of the cancer facilities, which we'll go into. So some of the advantages of this. So it's highly accurate for the ejection fraction, like we already talked about. It's reproducible, so you could do this scan and get the same ejection fraction a day from now, 5 days from now, if nothing changes. And if you want to detect subtle changes in someone's cardiac function over time, longitudinally, then it's ideal for it. And I think that's where it really is used today. And it's in patients that have had chemotherapy. So they will get an initial scan, and it'll show their ejection fraction, and then they'll get these chemotherapy agents, especially adriamycin, which is the one that we know right here. It's toxic to the heart muscle. So you'll give people cycles of chemotherapy, and you want to monitor that over time. So I don't know the exact time spacing that you would consider, but I'm guessing, every 6 months or so they go back, get a nuclear scan, and look at their ejection fraction. If it's staying the same, then you're thinking, oh, it's not very toxic to this person's heart. So they can, keep on going with their treatments. So this is an example of adriamycin used in a lymphoma patient. So this first radiograph, you can see the cardiomediastinal silhouette is, upper limb. It's not too bad. I would say it's normal. And then after a couple cycles of chemotherapy, it's 70% of the thoracic cavity is enlarged. So you might want to stop the chemotherapy cycle because you don't want it to kill the patient out of heart disease. So nuclear studies. So thallium and Tec-99 sesame B are common agents that are used. I think sesame B is probably the most common now. So what it does is it shows the perfusion of the heart. What you do is you're going to give a stressing agent after that. Like we were saying earlier, you have stressing agents, whether it be running, in this case, we'll say adenosine, which dilates the blood vessels of the heart. So you can use this if someone is unable to exercise, like give them adenosine, and unable to walk well, a female with suspected heart disease, evaluation of previous heart disease to evaluate suspected progression. Let's see. So it's pretty good at evaluating, 75–90% positive in those with significant disease, so that's pretty good. So I wanted to give you guys a little orientation of what, this is actually a thallium scan. So I want you to pay attention to the short axis, which is the top one. So what that is showing is all of these are renderings of the left ventricle, okay? So that's the thing you're most concerned about in a nuclear study. You want to know the function of the left ventricle. On the anterior side of the left ventricle and 2/3 the way down the anterior septum is the LAD distribution. The lateral distribution is the circumflex, and then the posterior 1/3 and the posterior of the heart is the right coronary artery, or PDA territory. So from there, if you can find a defect, in this case, you see at rest, very normal, all the way around. Stressed, there's a defect in the heart. So you know that there's an area that's getting ischemic when it gets stressed. That's kind of that scan. So I think this is another case, case 3. So what coronary artery is involved? I know this is a little tougher, but I'll let you guys think for a second. letters that anyone wants to guess? Just randomly?
D.
Actually, D is right.
Yay.
Good job.
Way to go, Beth.
So, I'll show you the diagram. So basically, what we have here is we have the resting image. This is, like I was saying earlier, this would supply the LAD territory, the circumflex territory, and then this would be RCA, posterior descending, all that.
Can you say
So-
that one more time? I'm sorry.
So the heart, so this is the side right here that I'm pointing at is the interventricular septum right there, okay? So that's more medial in the heart. This is the lateral side over here. So the anterior 2/3 of the septum, and I have another chart on this I'll show you. And the anterior of the heart is the LAD territory. The lateral side of the heart is the left circumflex territory. The posterior heart and 1/3 of the septum is the RCA, posterior descending territory. And I'll show you that a little bit more. So right here what we see is, this is obviously a defect. See how there's no perfusion here, and at rest there is some here. So that's a reversible ischemia with stress. This one right here, well, if you see there's a little red mark right here, and then it kind of got purple. So this is all just weighted from basically purple to black, or sorry, red oranges to black with perfusion, okay? How much radiotracer is there. So you know that there's a circumflex and an LAD ischemia. This one I left in here just to show you guys what a fixed defect looks like. So see this defect right here, and then you stress it, it's still there. That means that is dead tissue. So it's already infarcted tissue. That they wouldn't do anything about. It's medical management. But if you have this reversible defect, that's what a cardiologist wants to see. They'll go in there and revascularize the heart. So here's what I was talking about earlier, kind of the distribution. LAD's anterior, and it's supposed to be 2/3 down the septum. Circumflex is lateral. RCA is posterior 1/3, or sorry, posterior and 1/3 of the interventricular septum. And here's, it kind of tells you about it in here if you want to read later. So here's that thallium heart scan. Same thing. This is kind of what it looks like. If you ever see an image like that, that's what a thallium scan looks like. There's nothing really else to tell you about it. So indications for percutaneous transluminal coronary angioplasty, which is basically stenting. Okay, so it's basically let me think real fast. So the cardiologist has a high suspicion that you have a significant stenosis through all these things that we've been talking about earlier. This is a time that they pass, in this picture you can see they pass a wire, it's just a guide wire, past this stenosis, right? If they can pass this wire, then what they do is they insert a catheter over this, blow up this with a balloon, which is called angioplasty. So that's, percutaneous transluminal coronary angioplasty. So they blow it up with a balloon, and most of the time they just place a stent over this. There's a bunch of different types of stents. There's drug-eluting stents, bare metal stents. The list goes on. Again, you probably don't need to know much about that. But the indications that you do this is, we said earlier, single vessel disease, two vessel disease. There's a recent report, it's called Courage Trial, that questions harms and benefits of this versus just doing medical management. It was kind of interesting, but cardiologists are still doing this all the time because nothing's really changed after that trial. And then this is on the other side. This is what a cardiothoracic surgeon would do. So this is CABG. We were talking about it earlier with those median sternotomy wires. This is basically for someone that has, there's two real main reasons. One of them is they have triple vessel disease, which is the main reason. So if you have diffuse disease throughout your heart, you're not going to be able to go in there and stent everything. You just, it's just not going to work. Trials have shown that it's just, everything's going to stenose and you're going to have problems. So that's a main indication for CABG. Another indication is if you have the left main, which is the left coronary artery, before it breaks into the LAD and left circumflex, there's more than 50%. Or if you have two vessel disease and one of those involves the LAD. Because the left anterior descending and left main are your main supply of blood to your left side of your heart, which is all the pumping function to your body. So if you can remember triple vessel disease and your left main and left anterior descending are important, then those are the main indications for CABG. So ejection fraction in CHF. So there's a bunch of different ways you can do ejection fractions. We talked about the gated imaging, and it's the most accurate means. There's also ultrasound. There's what's called transesophageal ultrasound and transthoracic echo, it's the same thing. So transthoracic echo is the one that they do at bedside, and it's very easy to do. A TEE, on the other hand, the main indication for that is if they're going to put someone on blood thinners, say like you're going to start someone on one of the new blood thinners, and you want to make sure that they don't have a thrombus in their left atrium, you do a TEE. It's the main reason. 95% of the time you're doing it. So just start someone on blood thinners, make sure they don't have a left atrial thrombus before you do it. The only other time that you're doing a TEE is you're looking for septic emboli, right? So you're looking for, like someone has emboli to the lung and they want to rule out that you have, a myocardial source of infection. So they'll do a TEE on those people. Otherwise, there's not really many indications for it. So, and then coronary angiography, it's not really used for evaluating ejection fraction. It's more for treatment purposes like stenting. So a normal EF is over 45. So 45 to 70 is a normal EF. 40 or less, not so much. One of the big numbers to know, at least for us in medicine, was 30%. Once you get 30%, you start giving ACE inhibitors for CHF. So it just changes treatment a little bit. You guys probably won't be testing on that, I was just letting you know. We'll do a couple more pictures. So this is a side view, and the reason you know that this is a lateral is because, look, you got the spine right here, you got the vertebral bodies, then you have this calcification going along the aorta all the way down. So this is just, calcified plaque. You can see these on not very often on plain films, but it's very often you see it on CT and ultrasound.
You can see it at the carotids and the
Oh, yeah.
aorta
Yeah.
in plain films of your elderly patients.
Yeah.
Like that.
So aortic tear. So this is a patient that would present with severe back pain, or pain radiating to the back, feel like a tearing or ripping, may have a recent history of trauma or motor vehicle accident. Typically, what you see on chest x-ray is you see widening of the mediastinum. You might see some fluid tracking down the side. That's kind of what this is showing right here. This is angiography, which is the way that you diagnose. Well, typically today, you get a CT done with contrast, and it shows it, and they go straight to surgery. Because these people will die on the CT exam bed. But on this study right here, this is an angiography study. It shows, this is supposed to be smooth. This is supposed to be an aortic contour that's very, very smooth, and it's dissected completely, or ripped right here off this lumen. So, and again, a typical history is motor vehicle accident. Causes blunt dissection of the aorta.
So Princess Diana died from?
Yeah.
Murder.
Oh.
Murder from.
Conspiracy theories.
So that picture right there, is it actually out?
This one, I'm not 100% sure. I didn't get this from theirs. This looks more like a pouch. It doesn't look like it's leaking right now, because you see a little bit of extravasation right here. So yeah, it is. Never mind. You see this? This is the background color. It's supposed to be white. It looks like there is some leaking, but they probably had a patch repair already. Like they're basically shooting dye into the aorta, and see how this is kind of gray compared to this white. It's definitely leaking out somewhere. I don't really know. I don't really have the correct context.
No, that was good. I was just curious if it could be either.
It could be, I think, but I'm not 100% sure to tell you the truth. So this is another widened mediastinum. You can have an aneurysm of the aorta, and this just shows, the widening of the mediastinum. Again, non-specific. If you had this, you could say, if this chest X-ray, you could say, there's a widened mediastinum. Might consider getting, CT to look for aneurysm, or, ultrasound to evaluate. This right here shows you a plot within the descending aorta right here, the descending thoracic, and then you have a lumen. I think this is a true lumen in this picture, but over here, there's also a structure called a false lumen when you have a dissection. So you basically have an entrance. The vessel wall basically opens up, and you have an entrance of blood into there, and that is called a false lumen. Because sometimes you can mistake, the false lumen for the true lumen if you don't trace back the dissection flap, actually. So I think that's what that's trying to say right here. So for peripheral vessels, it's a combination of things, but most of the time you're using ultrasound. So when you're looking at vessels, you want to see if they're patent. You're worried about a DVT. You're worried about significant arterial stenosis. You usually start with ultrasound, and the reason is because it's non-invasive. You can get a fairly accurate study, and then from there, if you see a significant stenosis, you'll know whether to go to contrast angiography or magnetic resonance angiography, the same, an invasive test. So when someone has claudication, that means, they have trouble walking to the door without having, pain in their leg. That's usually a sign of arterial disease, like significant stenosis. So you would again start with ultrasound first, and then, if you see something significant, you'd probably go to angiography. And then if someone comes in and they have a PE, after that you're going to definitely look for a DVT and the deep veins of their legs, because that's the source of PEs majority of the time. So again, vessels, ultrasound's used for vessels the majority of the time. So whenever people are having strokes, you want to look at the carotid arteries, make the internal carotid arteries, make sure they're not stenosed. That's one of the main things they do in stroke now. So DVT, I think we went through a little bit of this earlier, but some of the risk factors for DVT. Prolonged bed rest or immobilization. So people had hip surgery, it's a big one. If you have hip surgery, you're kind of just laying in bed for a while, total joint replacements. Those are the people that get DVTs. Pregnancy, you have a hypercoagulable state during pregnancy, or when you take oral contraceptives, which is not in everyone, it's only in some people. Malignancy, you have also hypercoagulable state. And then, so initial evaluation, a D-dimer is sometimes helpful, not always helpful. It's because D-dimer is positive in a lot of cases that are not PE. If you have a lung infection, you're going to have a positive D-dimer. Anything that's breaking down any type of blood vessel, any type of blood clot at the time, you're going to have a positive D-dimer. So it's not very specific, but it is sensitive, meaning, a bunch of people, it's going to catch all the DVTs, like the positive D-dimers, but if you have a negative D-dimer, it's going to rule it out. If that makes any sense.
That's the more important thing.
Yeah.
If you're having a patient that's symptomatic, but you have a low suspicion and you want to rule it out, and you think it's going to be negative, you get a D-dimer and it is negative, then you don't need to go any further. If it's positive, then you need to order more tests to make sure you're ruling it out. That's the key.
Yeah, but I totally agree with that. That's a good scenario. But ordering a D-dimer and then using it as a tool to go to a PE next is probably not a good way to think about it if you're just ordering a D-dimer on any patient that has shortness of breath, because those patients with CHF, those patients with pneumonia, those patients with pretty much almost any chest etiology are going to have positive D-dimers. So you have to know when to order it to clinically make your suspicion high. Especially if they have any of these risk factors, I mean, that makes total sense. So evaluation of a DVT with echo. So this is what you do after a pulmonary embolism, or someone has something like that. So on the upper left, you see the femoral artery on the right and the femoral vein to its left. As you can see, what the ultrasound tech does is they take the probe over the femoral artery and the femoral vein, and they try to compress it as much as they can. What happens is the artery is not really distensible, it's thick-walled, so it doesn't compress, so it's right here. But the vein itself, it does compress. So they'll do that on all the different deep veins of the leg. This is a study right here where you have femoral artery, femoral vein. As you can see how this is what we call anechoic, or see how this is black, very black? That means that there's fluid in there. But this one right here is not very black. See, it's heterogeneous. There's mixed exogenicity within inside of the vein. So that's more indicative of thrombus. And then when they try to compress it, they can't compress the artery because that's normal. You can't compress the artery. But when they try to compress the vein, it doesn't compress. So that's a DVT. So let's see. So we're not going to see this video. Sorry.
Oh.
I know you guys are really disappointed. So what we have here is, so when there's a contraindication to anticoagulate someone, right? Is
an echo and a Doppler the same thing? So you do a Doppler?
So an echo. So yeah, Doppler is a setting on ultrasound
Yeah.
where you can look at flow dynamics. So you can, so yes, it's basically the same thing. You're doing the same thing on an ultrasound. You turn it into like a Doppler mode, and then it shows you basically like whatever direction you point the ultrasound probe in, you can get flow velocities, you can get a bunch of different things that show you flow dynamics. So that's really what Doppler is. Doppler just uses, have you ever heard the Doppler phenomenon, which is like, you know, like when a train comes at you, it's way louder than when a train's going away from you, but it's the same distance. It uses that same phenomenon to do with like blood vessels.
Is that what it like shows that red and blue?
Yeah, shows red and blue, so.
Going away and away.
Exactly, so whatever way you're facing the probe, you know, in the direction, you could do blue or red, and so you're basically just showing whether you can have like regurgitation or.
So what are the things they use in hospital before they're like, okay, give you the Doppler, and it's just like,
It's
they
like,
put it on there and they just listen to the flow? Like
so that's like a classic Doppler technology. They're just looking for like a heartbeat in like a baby or something.
Okay.
Like you put it, yeah, that's just like a Doppler. Most of these, like when we talk about Doppler, it's just using the Doppler settings on the ultrasound machine. So.
Okay, to do fetal heart tones, and then they'll use them on your fetal pulses too. So if you're worried about peripheral vascular disease and circulation, you're going to check in the emergency room or in your clinic, look at Doppler, because everybody's usually going to have one in their primary care area, but not an ultrasound machine.
So this right here is a IVC filter. I'm sure you guys have heard all the commercials about the IVC filter placement. You know, if you got a nice VC filter, you know, come sue this person as soon as possible. So these are put in as a last resort. Our IR docs don't even really like to put these in that much, just because they have problems with them, they have problems getting them out. But they are helpful in some cases. You're having, you know, you have a patient with a cancer that's causing multiple emboli, and they're gonna die from pulmonary emboli, or they get this. You'd rather have this, right? And a lot of people can't be anticoagulated successfully. They have bleeds, they have GI bleeds, they have intracranial bleeds. These are all reasons that, you know, you might think about doing an IVC filter at a last resort. So a couple of the other things we use in heart imaging, we use MRI, MRA, and then they use, you know, CT acquisition as well with contrast. So the good thing about MRI imaging is you get very, very high resolution imaging, and there's no radiation exposure because you're using just a magnet basically to get all your images. It's good for a lot of things. The problem with it is you can't have people that can't be in the same place for a long time. People have to be still. A lot of times these have to be non-emergent things because, you know, if someone's having a huge MI at that time, you don't want to send them into an MRI that's going to take, you know, 30, 40 minutes before they can, when they could have already been revascularized. So, but there are some things that MRI is good for, especially these things like neoplasms, wall evaluation, chamber size, just to look for enhancement in the walls. But we won't go too much into it, just know that it's there. So there's also magnetic resonance angiography. So if you're looking for an aneurysm, this is just showing cerebral MRA right here. So this is, you know, you have, you know, the carotids coming up, the middle cerebral arteries, the anterior segment, posterior segment. So you can just, if you want to evaluate for aneurysms, like Berry aneurysms in the anterior communicating arteries, for instance, which is a common spot, then you might do this. Okay, and here's another one, intravascular echograms. This is just basically looking for plaques inside the vessels instead of outside the vessels. This way, what's useful is this, is you get to see the actual lumen size. So why this is better sometimes is when you're looking on the outside of a patient, you don't really get a true view of the stenosis because you're not seeing the lumen in three-dimensional, right? You're just seeing a two-dimensional slice. So you're not getting a true stenosis of the artery or vein or whatever you're looking at. In this, you actually are. You're getting a three-dimensional picture of how much stenosed it is. So that's a real tool of intravascular echoes.
How does that perform?
These?
Yeah.
They just have a probe that they put on. Yeah, they just put a probe on the end of it. It's small. They put it on the tip of the catheter, and they go in there, and they can go in there a lot if you want to.
Oh, so you go in.
Yeah, they can go. They can. Yeah. And you can do, like it says here, you can do evaluation for angioplasty, and that's supposed to be stent with an E, by the way. Yeah. I think that's really pretty close to the end. So, and this is just multi-slice computer tone. This is basically CT. So, with CT, you get really, really good spatial resolution. So as you can see here, you see this RCA coming off the aorta. This is, remember, this is the front side of the patient. This is lateral. This is posterior. And this is medial. So here's the RCA coming off. There's little tiny stenoses. There's a stenosis right off the RCA. Here is some stenoses, and then you can see stent placement over the LAD, the left cert coming off right here. So you get really, really clear pictures off CT. And now they're doing a lot of different things. Coronary calcium score, which basically grades the amount of calcium within the arteries, and you can tell whether you need angiography from that. I think that's it, guys. You guys have any questions? All right. Sorry I'm done early, but I'm guessing.